everyone. Good afternoon. Thanks for joining us again in this Asian Lung Cancer Symposium, Part 2. So today with us are two faculty, Dr. Victoria Wang and Dr. Johannes Kratz. And thank you again for coming back, Dr. Kratz. This is the second time that you're coming for this town hall. And I want to thank Dr. Kratz very much for helping me to organize this Asian Lung Cancer Symposium so that we can offer that to the community. So this is what we're going to be talking about today. Dr. Kratz will speak first and talk about the state-of-the-art treatment in the early stage lung cancer. And then Dr. Wang will be talking about the state-of-the-art treatment for the late-stage lung cancer. So one's for early lung cancer and one's for late-stage lung cancer. Hey 各位多謝你哋各位參加我哋今日嘅講座。希望你哋亦都上次有參加我哋第一部嗰個講座啦。我哋好多謝 Dr. Kratz 啦，因為佢咧就係幫我一齊做呢個肺部嘅研討會嘅，咁係得到佢嘅幫忙，我哋今日先至可以做得到出嚟。今日咧就有兩部分啦，我哋有兩個講者啦，一個咧就係 Dr. Kratz 啦，一個咧就係 Dr. Wang 啦。Dr. Kratz 嘅中文名咧就叫做柯祖詒醫生。Dr. Wang 嘅中文名咧就係汪修宏醫學博士。咁咧一位咧就係講早期肺癌嘅醫療法，另外一位咧就係講晚期肺癌嘅醫療法。咁即係希望我哋梗係好希望大家係如果就算係朋友啊親戚啊有肺癌咧，都係希望佢哋係早期可以嚟揾到我哋去醫治啦，係嘛？咁咧就跟住咧就有一個問答嘅時間嘅。Dr. Kratz actually went to all the schools that parents aspire. He went to Stanford for his undergrad and he obtained a double major in biology and philosophy. He then continued and received a master's degree in philosophy. And then, of course, being as an outstanding student as he was accepted to none other than the Harvard Medical School. And then afterwards, he went to the famous Mass General Hospital for his surgical residency. He came to us at UCSF in 2014 for the fellowship in thoracic surgery. And fortunately, he decided to stay here in San Francisco as a thoracic surgeon at UCSF after his fellowship completion. So we are very fortunate that he decided to stay. Dr. Kratz has always been an outstanding student, outstanding surgeon, and he has received many awards over his young lifetime so far. The two most recent ones were received in 2017 and 2018. In 2017, he received the UCSF Health Annual Exceptional Physician Award. That is an award that's very difficult to come by. Only one of our thousands of physicians get to be named for that award. And then in the following year, he became the Auken Endowed Chair in Thoracic Oncology for his outstanding work. He is also currently the director for the Advanced Minimally Invasive Thoracic Surgery Section. 咁咧，柯醫生咧喺斯坦福大學嗰度咧就讀學士嘅，一讀咧就讀孖科喎，係生物系同埋哲學。咁咧佢咧就對哲學好有興趣啊，攞咗個碩士先走嘅。咁跟住做咗一兩年嘢咧，就決定去讀醫喎。咁咧佢咧就係一個好叻嘅學生啦。咁咧就俾哈佛大學收咗嘅。咁咧就喺哈佛大學醫學院畢業啦。跟住咧就喺麻省嗰個綜合醫院 Mass General 嗰度做外科醫生。呢個麻省綜合醫院咧係一個非常非常之出名嘅醫院嚟嘅。咁咧就佢咧就對外科特別有興趣。咁咧就喺嗰度做咗幾年實習之後咧。就喺2014年咧，就嚟到三藩市呢個加州大學嗰度咧，就係去做呢個胸外科嘅培訓嘅。咁做咗3年之後咧，就決定留喺 UCSF 嗰度咧，就正式做胸外科嘅醫生。咁咧，柯醫生當然係一個非常之優秀嘅醫生啦。咁佢得到無數嘅獎項啊。咁佢最近嗰兩個獎項咧，就係2017同埋2018年。喺2017年咧，佢係得到UCSF 呢間大學嘅每年度嘅傑出醫生獎，醫生獎係非常之難得嘅，因為幾千個醫生之中揀到佢出嚟。咁跟住嗰年咧，就因為佢傑出嘅成就咧，就做咗呢個胸腔腫瘤科嘅 Van Hawking 嘅主任教授。咁咧，柯醫生嘅專長咧，就其實係用呢個機械臂嚟到做呢個胸科嘅微創手術嘅。咁而家佢咧就係呢個部門嘅主管啦。咁佢今日咧就將佢呢個微創手術嘅精髓係帶嚟同大家分享嘅。 咁我哋非常之多謝柯醫生咧，喺完成佢嘅培訓之後咧，留喺 UCSF 嗰度做工，係等我哋嘅亞裔病人可以得到佢嘅幫助。
My pleasure. Thank you, everyone, for having me. These are my disclosures. Thank you for having me. I'm going to actually present robotic surgery in the eyes of what a patient might experience and what we might see in the office. I'm presenting Miss Y. She was a 68-year-old Asian female never smoker who presented to my office, and she had the finding of a nodule on her CT scan. She was otherwise healthy and had no family history of lung cancer.
柯醫生咧開始咧就介紹呢個病人咧，就係一個早期嘅肺癌患者。咁咧佢就係一個68歲嘅亞裔女性，從來冇食過煙嘅。咁咧突然間咧喺嗰個照片嗰度咧就發現咗喺個右肺嘅上葉嗰度咧就有粒嘢。咁初嘅時候咧，即係我哋睇佢嘅病歷咧，就佢係一個相當健康嘅人嘅，除咗係有少少關節炎啊、啲骨節痛嘅之外咧，就冇咩問題嘅，亦都唔係食咩藥嘅。咁又從來冇吸煙啦，又屋企咧又冇個肺癌歷史嘅。
So this is her CT scan, and if you look on the left side of the screen, you will see a white spot which represents her nodule.
咁呢個就係佢嘅肺照片啦，係嗰個 CT 嘅照片。咁大家睇到咧喺佢嘅右上邊嗰度咧
This was biopsied and found to be lung cancer.
咁佢咧就有一粒白色嘅點啊。咁當佢攞咗嗰個樣本出嚟嘅時候咧，就發覺原來係個肺癌嚟嘅。
She also underwent a PET CT scan, which showed that it was early stage lung cancer.
咁佢咧就再照清楚啲咧，就發覺咧原來佢真係有早期嘅肺癌，真係唔好彩啦。
So she was diagnosed with early stage lung cancer, stage 1A. And then as a faculty, we always think, what kind of resection should she get? Should she get an open resection, a minimally invasive resection, or a robotic assisted minimally invasive resection?
咁發覺咧，原來佢咧係有臨床呢個，我哋將嗰啲肺癌咧係將佢分期嘅，佢咧就係最早期嘅，係 1A。即係又未擴散啊，係又好細粒啊咁嘅。咁咧佢就喺 UCSF 咁當然接受治療啦。咁但係到底用邊個治療咧？有3個方法，一個咧就係開胸，照平時咁樣喺個胸嗰度切幾寸，咁然後就攞個肺癌出嚟啦。第二個咧就係用呢個視頻輔導嚟到切除，即係有個照相機咁樣幫個醫生去睇嘅，等嗰個地方嗰個位置咧係可以擴大幾倍嘅。咁跟住咧就係第3個方法咧，就係用呢個機器輔助切除啦，即係唔係用人手，係用個機器嘅手嚟到去切除嘅。
So if we look back to how robotics started, we have to start with how minimally invasive surgery started. So this started in 1910 by a physician named Dr. Jacobus, who looked inside the thorax of patients with TB or tuberculosis. And he used 3 things. He used a light source, which was actually a candle, and just local anesthesia.
呢個咧就係講一講微創手術嘅歷史啊。最初開始咧就係由呢個醫生 Jacobus 去開始做嘅，就係1910年喎，真係離開而家1個世紀以上啦。咁佢用3個方法啦，一個咧就係睇下係有冇咁嘅症狀去要做呢個手術啦。第二個咧就係睇下個光源係用咩啦。第3個就係睇下個麻醉藥係用咩啦。
After he did this, minimally invasive surgery in the chest was largely forgotten about because our medical therapies for TB got better. However, general surgeons began to remove gallbladders with minimally invasive surgery, and so we began to explore this again in the 1990s.
咁初由呢個醫生1910年開始咗做之後啦，咁跟住俾人遺忘咗啦喎。咁直至到1950，即係因為1950年嘅時候咧，就開始有呢個有啲藥啊嚟到抗生素嚟到幫啲人去醫病啦。咁直至到1990年嘅時候咧，就開始咧又翻出嚟咧呢個微創手術。因為點解咧？因為佢當時咧係有嗰啲用呢個空腹鏡啊去切嗰個膽囊。咁咧呢個切膽囊呢個手術咧就係可以用微創嘅手術去做嘅。咁個手術非常之成功。
And how we achieved this in the 80s and 90s was a few small incisions using very long, thin instruments that could only rotate and then open and close.
咁咧當時做咧就比較原始啲啦，咁要開3-4個窿啊，咁然後將啲有長臂嘅儀器咧就塞咗入去啊，咁但係咧佢喐嘅位置咧就係都相當係有限嘅，即係唔係你想點喐就點喐嘅。
And there were advantages to this kind of surgery: less pain, less time in the hospital, better recovery and faster recovery, and of course, improved look for the patients with smaller scars.
咁咧當然做呢個手術係有優點啦，雖然佢係有限度嘅做法，但係有優點嘅。第一就係少啲痛啦，第二嘅住院嘅時間非常之短啦，因為你開嘅位置唔多啊嘛。咁而且咧就減少感染啊，同埋個身體嘅受傷啊，同埋以後復原嘅免疫功能啊，咁樣都比較好啲嘅。同埋當然個傷口又冇咁大啦，係咪？咁喺對女士嚟講非常之重要啦。
However, there were also disadvantages. So instead of using our eyes, which are 3-dimensional, we had to look at a screen, which was 2-dimensional. The instruments were very limited in their range of motion. And we still had to be at the bedside to perform the surgery.
咁但係佢有優點啊，當然亦都有好多缺點啦。第一個咧就整係即係睇嘅視覺啊，係即係一個平面嘅視覺啦。咁而且咧就係嗰個做喐嗰個儀器啊，係唔係好靈活嘅？咁咧又失咗呢個手眼呢個協調嘅功能啦，即係你隻眼睇到嗰度，隻手上去咁樣做，但係隻手未必係做得到，將個儀器去到嗰度嘅。咁咧就另外一個咧就係你係個醫生係要喺個床邊嗰度做呢個手術嘅。
So that is why robotic surgery got invented. The first thing that we should clarify is what is robotic surgery. And unlike a self-driving car, there's nothing automatic about robotic surgery. There's no go or stop button on the robot.
我醫生咧就相當幽默，佢話咧就卒之咧，因為有啲咁嘅情況咧，就開始用呢個機械嘅臂手術啦。咁咧，但係佢話咧做機械臂手術咧就唔係好似揸自動車咁喎，你咁高咁就佢就去咁 stop 咁佢就停喎，佢唔會自己喐嘅喎，你都仲要個醫生去揸佢嘅，即係唔係話自動化嘅。
Robotic surgery is really just a name for computerized or digital instrumentation. So instead of us standing here by the bedside of the patient and using long, skinny instruments, this is replaced by a robot which holds very sophisticated instruments for us at the bedside of the patient.
咁咧，呢個手術咧，個醫生咧就唔使喺個病人嘅床邊嗰度做嘅，個醫生喺另外一間房嗰度嘅。其實呢個手術咧就只係用呢個電腦去控制嗰個機械人嗰隻手臂點樣喐，咁佢咧就係但係都係要個醫生咧係全程去控制佢嘅。
So here's the robot now holding those instruments, and we control the movement of these instruments through a fancy computer interface.
咁大家可以諗下，坐喺張凳嗰個咧就可能係柯醫生啦，坐喺張凳嗰度，佢咧就睇住個電腦，咁咧就係控制。另外左手邊嗰度咧，你咪見到有嚿嘢嘅，嗰嚿嘢就係嗰個機械人。咁咧呢個機械人咧有4隻手臂嘅，喺呢個情況有4隻手臂，每個手臂做一樣嘢嘅。咁柯醫生咧就喺另外嗰邊嗰度咧就係控制邊隻手臂喐邊度，行幾遠嗰啲咁嘅情況，所以係全程係由醫生控制嘅，但係佢就唔使喺病人床邊。
And you can see how, as my hands move in space, the robotic hands also move in the same fashion inside the patient.
咁你可以睇到呢幅畫圖咧，其實係分兩橛嘅，上面嗰橛咧就係俾你睇到真正嗰個機械人咧嗰個手臂咧係揸住啲針，另外嗰度好似揸住個鉗咁樣。下邊嗰個咧就可能係即係個針嗰個醫生。如果唔係做呢個咁嘅手術咧，佢就會喺下邊嗰度咧就會揸住一啲同樣咁嘅儀器咧，就去咁樣做嘅。
So why do we need this? Well, this is our minimally invasive instrumentation, our modern minimally invasive instrumentation.
我哋點解用呢個機器呢個臂呢個手術咧？咁就因為咧呢個係呢個胸腔鏡儀器嘅重大進展嚟嘅。
And this was our instrumentation in 1980, which is exactly the same.
咁呢啲咧就係以前嗰啲儀器啦嚇。
In fact, if I showed you this drawing, you might be surprised to find out that that drawing is pre-Civil War from the 1840s. So there haven't been any major advances in instrumentation for our traditional minimally invasive approaches.
咁你睇到咧就係嗰三幅圖咧，一個咧就係1849年嘅，一個就1800年嘅，一個係2020年嘅，即係最近一兩年啦。嗰啲儀器都差唔多嘅，但係佢而家 show 到呢張畫咧，有另外一回事啦。
But robotic surgery allows for us, instead of making a big incision and putting our hand with a lot of degrees of freedom inside the patient, to make a small incision and put a robotic hand inside the patient, which has the same ability to move in space as our natural hands.
完全唔用嗰啲咁嘅儀器咧，而家你就睇到佢嘅手咧，上面嗰隻係人手啦，下邊嗰隻就機械手啦。嗰隻機械手嘅喐度啊，其實比隻人手咧仲喐得好啲嘅，即係有啲地方係人手喐唔到、轉唔到嘅咧，個機械手係可以做得到嘅。咁呢個就係呢個用機械化嘅手術啦。
There's many other advances now that are coming. So, for example, in the upper left, there are now robots that just have lots of instruments through a single port. On the upper right, you can see that instrumentation is advancing, where it gives us feedback so we can start to feel with the robotic hands. And on the bottom, you can see how images are overlaid on the actual organs we're operating on in real time.
咁你睇到呢三幅圖咧，就係嗰三隻手臂就係做唔同嘅嘢嘅，大家都見到啦嚇，佢哋點樣喐啊，然後點樣去聯針啊，同埋點樣去入去個器官嗰度做任何嘅切嘅功夫啊咁樣，咁咧就係亦都可以你睇到咧嗰個器官嘅反應啊，佢嘅血嘅流量啊，諸如此類嘅。咁呢個咧就係而家呢個手術嘅非凡嘅進展啊，可以講係帶領我哋入去另外一個世界嗰度嘅。我亦都相信咧，即係呢個唔係啊。So Dr. Kratz, this is changing the landscape of surgery totally.
Yes.
Right. And then you expect that this type of robotic surgery actually will be applicable to many types of surgery in the future, that this would probably take over the regular traditional surgery, right?
Traditional minimally invasive surgery, yes. This is the new way to do it.
Yeah. 咁而家咁樣用呢個機械人咧，就係即係將個微創手術咧係更上一層樓啊！將來係會繼續係會做得仲多嘅。
Even now, we are using advanced visualization of nodules in the lung, so we know exactly what part of the lung to resect.
你而家睇到咧，佢係用嗰啲鏡頭咧，係睇到直情係睇到嗰粒腫瘤嘅位置嘅，所以切出嚟咧係非常之準嘅。
So those are the reasons why, for Miss Y, going back to our patient, we selected a robotic-assisted minimally invasive lung resection.
咁所以咧，係對 Y 女士嚟講咧，佢係第一期腫瘤嘅第一期，即係嗰粒腫瘤係咪咁大啦？所以咧喺3個嘅切除方法之中咧，柯醫生咧就係揀除咗呢個機械臂輔助呢個肺葉嘅切除術嘅。
Here are some pictures from the operation which show the advantages of using the robot to do very fine manipulation in space.
呢個咧就係又係用嗰啲機械人嗰啲手臂啦，就係擠咗入去，咁即係你見到都唔係用人手去做嗰個手術。佢係用人手啊，但係個人咧係坐喺另外一間房嗰度嘅，佢係用個電腦去控制呢啲儀器點樣喐嘅。咁咧就係用呢個方法咧，就係將嗰個胸口嗰個膜啊，將裏邊嗰啲淋巴結咧係逐粒咁除晒出嚟嘅。
So Miss Y had her robotic lobectomy, and then she came back to us and said, "Do I need anything else after my surgery?"
咁兩個做完手術2個禮拜之後咧，咁Y 女士咧就走翻嚟話：咁我仲需唔需要做啲乜嘢㗎？
One of the problems is that even after we do lung resections, early stage lung cancer often recurs.
有其中一個問題難處咧，就係雖然我哋係將嗰個腫瘤切除咗咧，但係第一期呢啲肺癌咧，好多時咧都會翻發啊，個風險係非常之高。
So at UCSF, we invented a test that helps determine whether lung cancers come back after surgery. And you can see in the graph on the right side that as the risk score by this test increases, the probability of lung cancer coming back also increases.
喺 UCSF 咧，就因為佢翻發嘅風險高咧，就做咗一個風險嘅評估嘅。咁你睇到咧喺呢幅圖白色嗰個畫面嗰度咧，就係有不同嘅風險啦。譬如年齡啊，有冇吸過煙啊，有冇做過化療啊，諸如此類啦。咁如果佢越多風險咧，咁翻發嘅機會咧就係越高嘅。你見到嗰條線咧，就係個風險如果越高，向右邊嗰度去越高咧，佢翻發嘅風險咧就係直上嗰度咧就係越高嘅。
So we developed this test at UCSF, but importantly, we also had two large validation cohorts where we tested this assay on. And one of them was from Kaiser Northern California, but the other was over 1,000 patients with resected lung cancer in China.
咁咧，我哋係咁講啦，係咪？就係話你如果做咗呢個風險嘅評估咧，我哋就可以估到你嘅翻發嘅機會幾多。咁但係到底實際上係咪真係可以估到咧？估到嘅程度吻唔吻合咧？準唔準咧？咁咧就呢個嘅風險評估咧，就係喺兩組嘅病人嗰度試驗過嘅。一組咧就係用Kaiser 醫院嗰啲病人，另外一組咧就係用中國嗰度嗰啲有肺癌嗰啲病人喎，即係非常之遠啦。咁總共夾埋咧有成1400幾個病人咧係做過呢個咁嘅風險嘅評估嘅比較嘅。
And you can see in both cohorts that although the outcomes of these patients are supposed to be very similar, that the assay or the test identifies patients in red here who have a much higher chance of their lung cancer coming back and them dying of their lung cancer within 5 years of their surgery.
左邊即係打直嗰度咧，就係佢嘅生命嘅時期。咁當然係嗰條線越低咧，個生命就越短啦，係咪啊？咁咧高嗰度咧就係藍線啦。咁你見到紅色嗰條線咧係最低嘅。咁你發覺咧就算係喺中國做又好，喺 Kaiser 嗰度做又好咧，大家睇到得出嚟嘅結果都相同嘅，即係話呢個風險評估係相當準確下咯。
So at UCSF, after patients undergo robotic lung resection, we then test the tumors, and those patients who are on the green or red line, we actually refer for medical chemotherapy after surgery.
因為佢係第一期嘅病人啦，咁咧第一期嘅病人好多時切咗出嚟就可能冇事噶啦，話唔翻發噶啦。咁到底邊啲人先至要繼續又做化療啊，又做電療？咁到底你點樣揾咧？咁佢而家做咗呢個咁嘅風險評估出嚟咧，就當然知道啦，係會嗰個生命線如果係短啲嗰啲人咧，就將佢去繼續做化療電療，就希望佢增加生命嘅延長嗰個生命。咁所以咧，你睇到咧喺呢幅圖嗰度咧，佢就將嗰啲喺紅線啊或者綠線嗰啲病人咧，即係個生命期短啲嘅咧，就叫佢去做化療同電療，而藍色嗰條線嗰啲咧，就可能就咁做咗手術就得啦。
And we've shown that giving chemotherapy to those patients on the green and red lines dramatically improves their outcomes, and they have the same outcomes as patients on the blue line.
咁咧，亦都係喺研究嘅結果出嚟咧，就發覺如果係我哋咁樣做咧，將嗰啲喺紅線同埋綠線嘅病人咧，將佢去叫佢去做化療或者電療咧，佢得到出嚟嘅結果啊，係個生命率係會將佢提高到好個藍線嗰度嘅。咁所以就係唔係淨係做手術咁簡單，做完手術之後咧，佢係會繼續去調查一下呢啲病人有邊啲人做完手術之後要做化療同電療。咁而家咧就用呢啲咁樣圖咧去分開佢，然後咧就繼續去叫呢啲人做手術做化療電療，就將佢哋嘅生命拉長嘅。
So Miss Y had the test run. She had high risk disease, and she received adjuvant chemotherapy after resection of her stage 1 lung cancer.
咁咧，呢位Y 女士咧就發覺咧，呢位 Y 女士原來係一個高危群組係可以即係可以翻發嘅高危群組啊。咁咧就於是咧柯醫生咧就將佢轉咗去開完手術之後，就轉咗去腫瘤科嗰度去做呢個輔助化療啦。喺1個月之內開始做。
She's currently doing well without any signs of recurrence 5 years after surgery.
咁5年之後咧，佢而家嘅身體情況咧仲係非常之好嘅。Congratulations, that's big success. So 多謝柯醫生俾一個咁有趣嘅 case 我哋睇，所以我哋醫生咧即係同嗰啲唔係淨係自成一角話哦，我做手術做完啦算數，唔係咁嘅，係同其他嘅醫生係有商有量，將嗰啲病人嘅情況係盡量做到最好嘅。Thank you.
Yep, there will be time for answering the questions that are starting to crop up afterwards, but I'd like to introduce Dr. Wang.
咁以後咧就係我哋遲啲會答你嘅問題嘅。咁而家首先咧就同阿汪醫生傾下偈先。
So Dr. Wang and I followed extremely similar pathways in our education. She actually also went to undergrad at Stanford University. She also went to Harvard Medical School. She additionally has a PhD from MIT. Then she went to the Massachusetts General Hospital for her internal medicine residency, followed by UCSF for her oncology fellowship.
咁咧，阿汪醫生咧又係精英嚟嘅，同阿柯醫生咧一樣，係首先咧就去史丹福大學嗰度讀學士啦，跟住咧就去哈佛大學嗰度咧就讀醫學博士啦，咁然後咧讀完醫學博士咧，佢仲多一樣嘢喎，佢仲去 MIT 嗰度咧攞多一個博士係研究腫瘤嘅喎，咁做完之後咧，佢又跟住咧又去呢個麻省呢個總科醫院嗰度去做實習嘅，咁而家咧又一齊咧又嚟 UCSF 喎，咁佢哋阿柯醫生同埋阿汪醫生可以算係老朋友啦，因為佢哋喺哈佛大家讀醫學院嘅時候已經認識咗㗎。
Thank you for having me today. And now on to lung cancer. And so my name is Victoria Wang. I actually didn't enclose a disclosure slide, but I do receive research support from this company called Inhibrx. And then I'm one of the investigators on their clinical trial, and I'm also involved in a BioAtla trial.
咁咧，汪醫生咧就冇講佢自己嘅披露自己嘅研究嘅，但係佢係有同一間藥公司做研究嘅。
So I will start out by talking about the types of lung cancer. Basically, lung cancer can be divided into two major types. One is small cell. Small cell is relatively rare and then is typically associated with smoking. It only accounts for approximately 20% or less of all lung cancers. But the focus today will be non-small cell lung cancer. And non-small cell lung cancer can further be divided into 3 different subtypes: adenocarcinoma, squamous cell carcinoma, and a very rare zebra called large cell.
癌症咧就主要有2類型嘅，一個咧就係叫做小細胞肺癌，一個咧就係非小細胞肺癌。你睇到佢唔係話叫做大細胞，唔係話大同小喎，佢一個叫小細胞，一個叫非小細胞，好得意嚇。咁咧就係有呢個主要嚟講咧就係小細胞肺癌咧係即係好少部分咯，5個人之中先有一個。咁咧非小細胞肺癌咧就係主要嘅，5個人之中咧有4個係嘅。咁咧喺呢個非小細胞肺癌之中咧，亦都分開3大類嘅，係睇個細胞嘅結構啊。咁咧一個咧就叫做adenocarcinoma 啦，就係一個叫做腺癌啦，一個咧就係squamous cell 中間嗰個咧就叫鱗狀嘅細胞癌啦，一個咧就係叫大細胞癌呢個 large cell 啦。So this is just your pie thing, right?
Yes, showing what percentage represents each type of cancer.
咁呢個咧就係一個圓圈咧，就係分開嚟睇到咧，差唔多大部分嘅咧都係呢個腺癌啦。咁然後咧呢個小細胞癌就係咁多，然後呢個鱗狀癌咁多。呢個咧就係嗰個大細胞癌就係呢個20% 啦。唔係呢個就係呢個20%，呢個紅色呢個。咁咧你分到睇到咧，大部分咧，即係呢個係分開吸煙同唔吸煙咯。呢度係呢個腺癌， 係有大部分係吸煙嘅，但係都有細部分係唔吸煙嘅喎。但係喺呢個小細胞肺癌之中咧，就大部分都係食煙嘅。
And so for the purpose of today's discussion, we're going to focus exclusively on non-small cell lung cancer. And so as I mentioned before, the most common subtype of non-small cell lung cancer is adenocarcinoma. And adenocarcinoma arises from the glandular cells of the lung that normally secretes the mucus. This is the subtype that is most commonly associated with non-smokers, female demographics, and it comprises about 70% of all non-small cell lung cancer. So squamous cell is the next most common. This arises from cells that lines the airway and is often associated with smoking. It's comprised about 20 to 25% of all non-small cell. And the most rare type is what's called large cell lung cancer. This is thought to arise from epithelial cells of the lung. It's typically associated with smoking, is the least common, only 5 up to 10%, and it grows very quickly.
咁呢幅圖咧就係再解釋清楚呢個肺癌啦，就係主要嚟講咧就係有呢個非小嘅癌細胞嗰個肺癌咧，就係分開3類。咁咧第一類咧就係呢個腺癌，呢個腺癌咧就係大部分嘅非小細胞嘅肺癌嘅，咁咧就佔咗成70%。咁有一部分係非吸煙者嘅喎。係同女性係有好大嘅相連嘅，所以好多女性係唔係吸煙嘅人咧，佢有肺癌嘅時候咧，就係呢種癌啦。咁咧，另外一種咧就係呢個鱗狀嗰個啦，鱗狀嗰個咧就大概係2%至2.5%嘅人有啦。咁咧呢啲人咧就係同吸煙係有關嘅，即係好多人都係食煙嘅，而佢嗰個肺癌嘅地方咧，通常喺嗰條大支氣管嗰個分叉嗰個位嗰度，咁生啲細胞好似一塊好似啲鱗狀咁，所以叫做鱗狀細胞癌。咁第3個咧就係比較少啲啦，呢個大細胞癌就係中間呢個啦。咁咧呢個大細胞癌咧就係通常生長喺個肺臟嘅表面嗰度，喺個肺嘅面嗰度嘅。咁咧就因為佢生喺個面啦，所以佢個擴散速度咧非常之快，咁咧就容易轉移去到啲淋巴結啊同埋其他嘅器官，所以呢個嘅大細胞癌咧係唔係幾好嘅。咁咧就係雖然唔常見啦，但係佢嘅生長速度快啦，同食煙有關。
Basically, the survival of non-small cell lung cancer is correlated to stage. And so stage 1 and 2 typically only require localized treatment as those described by Dr. Kratz, either surgery or radiation. Stage 3 is a very complicated field, and usually treatment requires multidisciplinary approaches. And stage 4 is entirely almost all systemic approaches.
咁咧呢幅圖咧，真係睇見都好傷心下嘅，因為呢個係個5年嘅生存率啊！我哋講肺癌咧，好多時係講5年嘅生存率，唔係講10年、15年、20年嘅生存率嚇。咁咧喺5年嘅生存率之中咧，如果係第一期，如果醫生話你係有第一期肺癌嘅咧，咁個生存率咧都相當高嘅，係成7%至9%嘅。咁咧就跟住就一路咁滑落啦，第2期就少啲啦，5-6成啦。咁第3期嘅生存率咧就真係得3成4成咁上下嘅啫，最多。咁然後咧就如果係話第4期嘅肺癌咧，就只係得1成咁上下嘅。咁咧所以個生存率咧係通常咧係睇下你發現你個肺癌嘅時候係第幾期，同嗰個第幾期咧係非常之有關係嘅。
So for the topic of our discussion today, what constitutes late-stage lung cancer? So broadly defined, late-stage lung cancer typically means those that have stage 3 and 4 disease. And stage 3 is further divided into stage 3A, B, or C. Without going into very exquisite detail, basically stage 3 is disease that involve these N2, which are the mediastinal lymph nodes here, or N3, which are the superclav lymph node here, or there are multiple tumors on the same side of the lung. And so the key takeaway here is that stage 3, with multidisciplinary modalities and some luck, is curable. And by multidisciplinary modalities, we typically means a combination of surgery, radiation, and chemo.
咁咧，我哋首先就做下一個定義先啦。乜嘢叫做晚期嘅肺癌咧？晚期嘅肺癌咧，主要嚟講咧，就係第3、第4期嘅肺癌。咁而第3期咧，就係一個非常之繁複嘅定期嚟嘅，因為佢咧係分開3A、3B、3C。咁點樣分 A、B、C 咧？就睇下呢個淋巴結嘅問題啦。如果佢嗰個肺癌係去到某一個部位嘅淋巴結咧，譬如個鎖骨上面啦，或者係個胸中間嗰個膜嗰度啦，咁即係兩個肺中間嗰度有個膜隔開咁。如果去到嗰度啦，或者係喺個橫膈膜嗰度啦，咁咧就係由呢啲咁嘅位置咧而鎖上佢係3A 啊，呢個3B 嘅3C 嘅。咁咧，如果有第3期嘅肺癌嘅時候咧，就開始咧就要用呢個多模式嘅治療去醫噶啦。咁啊，多模式係咩咧？多模式即係話手術啦、化療啦、電療3管可能一齊下嘅。
So there are 2 particular scenarios which I would like to mention for stage 3 patients. The first one is for patients with an EGFR mutation who are stage 3 that have undergone surgery, okay? They should get up to 3 years of this drug called Tagrisso. This data was very recently published that for patients with EGFR mutations that get those 3 years of Tagrisso, there is both a disease-free survival as well as an overall survival benefit based on this large randomized phase 3 trial. The second scenario is that for patients who are not resectable and get treated by a combination of chemo plus radiation therapy, okay, those patients should get up to 1 year of a drug called durvalumab. Okay, based on the Pacific trial, those patients with 1 year of durvalumab also has a survival benefit.
第3期嘅肺癌嘅病人咧，就睇下佢有2個環境嘅，一個咧就係如果有呢個 EGFR 嘅變種嘅時候咧，佢咧就要用呢隻藥咧 osimertinib 位，咁咧就我都冇翻譯到啦，就係要用到如果用咗3年呢個藥咧，咁咧佢呢個生存率啊係會增加到65個月，65.8個月，即係差唔多6個月，即係5年半㗎咯。就instead 即係如果唔用嘅藥咧，咁就係得2年幾嘅生命嘅啫。咁所以咧就係用呢個藥咧，用3年咧係非常之重要嘅。如果佢係呢個係切除咗之後，跟住用呢隻藥 ，OK？ 咁咧，但係如果係有啲病人咧就唔可以切噶嘛。咁如果佢唔可以切除嘅話咧，咁佢咧就用化療同埋電療啦。咁咧，如果佢用化療電療嘅時候咧，如果用呢隻藥啊，呢個durvalumab呢隻藥咧，如果係佢有用嘅話，佢咧就會個生存率咧係會有長過1年嘅得益嘅。咁所以呢兩隻藥咧，對有癌症嘅病人嚟講，第3期嘅病人嚟講係非常之重要。
So now moving on to stage 4. What constitutes stage 4? So stage 4, simply put, is when the lung cancer has spread outside the lung. Okay, and then common places that stage 4 disease can go includes the bone, the liver, the adrenal, and the brain. Unfortunately, there's currently no way we can cure stage 4 disease. So the goal of treatment is basically systemic treatment, trying to control the symptoms associated with the cancer, improve quality of life, and also improve survival.
咁咧，第4期係點咧？嗱，正話第3期咧就係話佢喺嗰啲淋巴結嗰度，即係嗰啲肺癌 去咗個淋巴結嗰度啦。但係第4期咧就唔止喺淋巴結啦，就係嗰啲肺癌啦，去到身體其他嘅主要器官啦，譬如個心臟啦，譬如個腦啦，譬如個肝啦，或者係嗰個腎啦，咁去到呢啲咁嘅地方咧，我哋唔可以再用呢個切除術噶啦，唔可以再用 surgery 噶啦，咁咧就唯有只係可以用呢個化學療法，或者係用免疫療法，或者用標靶療法去治療佢嘅。
The paradigm that we follow for treating stage 4 disease is first, we need pathological confirmation as to what type of lung cancer it is. And the second step is actually very, very important, and I cannot emphasize it enough. Okay, basically, when a patient is treated at UCSF, we always do molecular profiling to see if the tumor has some kind of mutation for which we have a drug. Okay, our preference is to do this test using the actual tumor tissue. However, if there are reasons that we don't have sufficient tumor tissue, a suitable alternative would be this liquid biopsy where we can do it from the blood.
病人如果嚟到 UCSF 嘅時候，我哋會點做咧？第一件事咧就係確定佢哋嘅肺癌真係有肺癌啦，個細胞係證明咗啦。咁第二樣嘢咧就跟住咧就係一定會做嘅咧，就係做呢個分子譜嘅分析啊，即係睇下佢嗰個肺癌裏邊嗰個DNA 嗰啲嗰個情況係點樣樣，然後咧知道咗個情況啦，知道佢有咩突變嘅因子咧，咁咧就要揀一啲適合佢嘅標靶嘅治療啦。如果係我哋係首選就係將個腫瘤組成第二代嘅測序啦，咁咧如果個組織唔夠啊，或者係攞唔到，因為有啲人係攞唔到嗰個，我唔係幾明點解攞唔到個活檢啦。咁咧，如果冇攞唔到嗰個組織嘅活檢咧，就係液體嘅活檢咧，都係可以替代嘅。總之就係要查佢嗰個基因嗰個編序啦。
So here I'm just showing a table of all of the type of mutations currently we have a drug for. And so if the patient is unlucky enough to have lung cancer, but lucky enough to have one of these mutations, okay, we have a drug that can be taken orally for the patient. And the benefit of these types of drug, we call them targeted therapy, is that it's more convenient. They can take them at home. There is also less side effect compared to the traditional chemotherapy.
好似好繁複咁，係咪啊？其實只係俾你睇下嘅啫，唔係要你樣都知道嘅。你見到呢度一條條線嗰度咧，每一樣咧都係一個基因嘅突發，就係呢個同肺癌有關嘅基因嘅突變。咁呢啲如果個病人唔好彩有咗肺癌咧，但係好彩俾我哋發現到佢有某一種嘅基因突變係喺呢幅圖上面嗰啲字咧。如果係有嘅話咧，咁我哋就知道用邊種嘅標靶治療可以對症下藥，去針對呢種基因嚟到將佢鎖死。咁所以咧，呢個 targeted therapy 呢個靶向嘅治療咧，係一啲口服藥，非常之昂貴嘅口服藥，又唔係好多嘅副作用，最多都係有啲嘔心啊，或者係免疫嘅壓制啊咁樣樣。咁所以咧，如果係呢個可以算係話，如果我哋揾到嘅話，就係不幸中之大幸咯。咁咧就亦都可能會做化療啦，或者係做呢個免疫嘅治療啦。咁呢個免疫嘅療法咧，就係比其他嘅癌症多啲嘅。咁只係我哋想話俾你聽，有不同嘅基因突變嘅個肺癌，所以唔係一種肺癌，係好多種肺癌嘅。
So if the patient does not have any targetable mutation, okay, the first line treatment is a combination of immunotherapy and chemotherapy. So the commonly seen side effect of chemotherapy would include immune suppression, nausea, hair loss. And the commonly seen side effects for immunotherapy would involve usually your immune system attacking some organ in your body causing inflammation of the thyroid, of the liver, of the lung, etc. There are many different types of chemoimmunotherapy currently being approved. There are subtleties between all of these different regimens. The one that we tend to use at UCSF are the top two. And the reason we try to use those two preferentially is because they have the longest follow-up with the most mature data.
就正話嗰啲基因突變咧，如果查到出嚟，咁就可以用嗰個排向治療啦。但係如果查唔到出嚟嘅咧，咁我哋就唯有要用化療或者係用呢個免疫治療啦。咁呢個免疫治療咧係有好多化療同即係免疫治療都有好多種藥嘅，好多時都係夾埋嚟用嘅，即係一隻化療即係一隻係化療用嘅，一隻藥係免疫治療嘅咁所以咧，我哋喺 UCSF 嗰度咧，就通常咧就係用即係黃色嗰度寫住嗰兩種咁嘅藥嚟到做同呢啲病人去做化療同埋免疫治療嘅。咁主要嚟講咧就係嗰個免疫治療就係可能會令到身體有一啲器官咧就個免疫嗰個情況係轉差啦。咁咧就化療嗰度咧就可能有啲其他嘅副作用啊，譬如甩頭髮啊、作嘔啊諸如此類嘅。咁所以就但係佢發覺咧就係如果用呢兩種咁嘅頭嗰兩種即係616同埋559呢兩個咁嘅 number 嘅藥嘅組合咧，就係可以將嗰個病人咧係可以將佢個生存率咧係拉到最長嘅。嗰個中位數字咧，一個咧就5年可以拉到，另外一個咧就都可以拉長7.8個月嘅。
So now I'm going to talk about each of the targetable mutations one by one and what the options are. So the most common is EGFR. This accounts for about 15% of basically of all of the non-small cell. So for almost all EGFR mutations, with the exception of exon 20, the universal consensus is Tagrisso. Tagrisso penetrates the brain. It has both an overall survival as well as progression-free survival compared to the first and second generation drugs. And currently, there are several large randomized phase 3 trials going on to try to improve upon Tagrisso monotherapy listed here.
而家咧，我哋咧就會係逐個主要嘅突變基因咧係講一講嘅。咁如果係呢個有 EGFR 呢個突變嘅非小細胞嘅肺癌咧，大概係即係1成半嘅人咧就係有呢個突變啦。咁咧就發覺咧，如果係用呢個 Tagrisso 呢種藥咧，就會可以拉長佢嘅總生存期啦。咁同埋咧就係可以令到佢嗰啲癌症咧係唔會繼續發展落去，即係更加犀利嘅。咁就即係呢個藥係有好處咯，就而家咧就有啲實驗啊，係為咗呢個 EGF 嘅突變咧，係做一啲一線嘅藥物試驗嘅，即係用邊隻藥做第一次嘅治療好啲咧，咁就有2種嘅藥咧，已經係喺第3期嘅實驗嗰度做緊噶啦。咁咪希望個成績會話俾我哋聽，邊種藥係對呢個有呢個 EGF 突變嘅病人係會更加有用。
So what happens if Tagrisso stops working? So the main message I would like to emphasize is when those people stop responding to Tagrisso, we strongly, highly recommend a repeat biopsy to figure out if why they stopped responding, because we may have drugs that we can again match them so that they could stay on some kind of targeted therapy. If we cannot find a targeted agent for them, the standard of care is to transition to chemotherapy. But there are also a lot of newer drugs that can be used in these patients, including antibodies, antibody drug conjugates, and newer generation targeted therapy small molecules.
咁咧就係話，如果係呢個 Tagrisso 咧，係會幫啲病人幫到一段時期之後咧，咁佢可能個病人咧就個身體冇反應啊，咁即係嗰啲癌症細胞咧又開始翻嚟啦，控制唔到啦咁。如果到咗咁嘅情形嘅時候咧，好多時咧啲醫生咧又會叫啲病人咧再做多一次活檢， 再抽翻啲癌細胞，因為佢生翻啲癌細胞啦嘛，抽翻啲新嘅啲癌細胞出嚟咧，再做活檢，睇下佢呢啲新嘅細胞咧，會唔會係其中一個突變咧？我哋可以有藥去醫嘅。如果揾到咧就最好啦。如果就算揾唔到咧，我哋都有其他嘅方法繼續同呢個病人去醫治醫療，等佢可以將嗰個存活期係增加嘅。咁啊，化療啦。有啲特別嘅抗體啦，同埋有啲係抗體加埋一啲嘅藥物一齊噶啦，咁所以咧就係有不同嘅方法咧，都係可以幫到呢啲病人嘅。
A special case is for the EGFR exon 20. This is rare, only about 1% of all non-small cell lung cancers. So this type of mutation does not respond well to Tagrisso. So the first line is chemotherapy. And after chemotherapy stops working, there are two drugs which are approved in second line called amivantamab and mobocertinib with a response rate of about 40%. And then also on the next slide, there are many active agents which are currently in clinical trial. That could penetrate the brain, that also have demonstrated a better response rate than the current approved two drugs.
咁就算喺呢個 EGF 嘅突變嘅因子嗰度咧，都有不同嘅分子片段嘅喎，即係唔係話淨係一種 EGFR 嘅喎。咁如果有一種嘅特子片段咧，係有一個呢個特子片段20嘅冇咗呢個特子片段20嘅咧。咁如果喺呢個情形之下咧，其實係非常之少嘅，少過1% 嘅。咁我哋咧就唔可以用 Tagrisso 呢隻藥嘅，因為冇效嘅。咁所以我哋係做啲嘢咧，就係啲醫生係非常之清楚，你嗰啲突變係點樣啊？邊隻藥有效啊？如果係嗰隻 Tagrisso 冇效咧，咁啊跟住點啊？咁喺呢個情況咧，佢就話如果係 Tagrisso 呢隻藥咧冇效嘅咧，咁你都可以用其他藥去做呢個化療嘅。咁啊用咩藥咧？就主要嚟講咧，就係用呢個 amivantamab 啦，同埋呢個 mobocertinib。做啦，咁我都唔識讀呢啲字，因為太過難，所以你哋都唔需要記。總之咧，有兩隻藥可以幫佢哋嘅。呢兩隻藥嘅藥性咧係可以幫到40%嘅人嘅，咁都相當之好。咁啊，另外咧就係跟住呢個 slide 咧就仲多啲嘅藥可以幫嘅。
And so I also wanted to talk about ALK mutation, which is the second most common targeted mutation in non-small cell lung cancer of about 5%. There are 4 different approved agents in the front line. They're all very active. They all have brain activity, but our preference tends to be alectinib because of the 4, alectinib in our experience has the best side effect profile.
咁呢個咧係亦都係一個基因突變啦，叫 ALK gene 嘅突變啦。咁咧呢個突變嘅時候咧，我哋發現咧，有另外一隻藥咧係比較對佢好啲嘅。就呢隻藥咧就係呢個alectinib。就係呢個字啊 ，OK。總之你哋記得咧，就係某一啲嘅基因突變咧，係咩情況之下咧，佢就會用咩嘅藥？呢個係醫生嘅專長，佢哋係會盡量會揀啲最啱你哋嘅藥俾啲病人嘅。
KRAS has been in the news a lot lately. Okay, KRAS is about 25% of all non-small cell lung cancer. And the frontline option is actually chemo plus immunotherapy. However, if the patient has a specific type of KRAS mutation called KRAS G12C, which is about 14% of non-small cell lung cancer, there are now 2 approved agents, sotorasib and adagrasib, available in the second line. Response rate is between 30 to 40%.
咁大家又睇到咧，呢個 KRAS 呢個基因突變咧，係最近咧喺嗰啲新聞嗰度咧，好多時都有講嘅。喺個癌症之中咧，大概有2成半嘅人係有呢個咁嘅基因突變。咁你睇到咧，佢亦都係主要嚟講係用化療同埋呢個免疫療法嚟到幫呢啲病人去做一線嘅治療嘅。咁咧，但係咧有一個咧，如果佢有一個 G12C 呢個突變嘅基因喺度咧，咁咧就有2隻藥咧係特別係對呢個突變有好處嘅。又係咁講啦，就係即係啲醫生就係對呢啲基因啊，邊個嘅突變啊，邊啲藥做化療啊，邊啲藥做免疫療法啊，點樣用法啊，咁佢哋係真係精英嚟咯。非常之清楚，又知道係乜嘢嘅實驗喺度做緊，有啲咩結果。
So RET fusion accounts for about 1 to 2% of all non-small cell lung cancer. There are 2 approved agents called Rotempo and Gavrotol. One is taken twice a day. The other is taken once daily. Both agents are very active with about a response rate of 80% and have excellent brain penetration. And so either one would work for this population.
咁如果有呢個 RET 呢個 RET 嘅基因突變咧，雖然係人數少嘅1至2% 嘅人有啫，但係咧佢嘅藥嘅效用啊係非常之高嘅。咁呢兩隻藥咧，你睇到咧一個咧都有成7-8成嘅人咧係會對呢個藥有反應，即係話可以控制到個癌症。咁所以即係而家嘅癌症病人咧，雖然係可能係得到癌症非常之個心唔開心啦，但係都唔使咁絕望嘅，因為其實而家真係有好多藥係可以幫到你哋。
ROS1 fusion is about 2 to 3% of of all non-small cell lung cancer. The current first-line treatment is this drug called crizotinib. However, there are at least 3 agents which are currently in clinical trial. Repotrectinib should be approved later this year, I would expect. And repotrectinib is much more active than crizotinib and also has better brain penetration. The main side effect here is dizziness.
咁呢個有另外一種嘅基因突變係叫做 ROS1，大概係2至3%嘅人係有嘅，即係患咗癌症嘅人係有呢個基因突變嘅。咁咧而家最主要嘅治療咧就係用呢個 crizotinib， 就係咧就除此之外咧就另外有3隻藥啊喺嗰個研究嘅排緊隊做緊研究嘅。咁咧希望咧呢3隻藥咧就快有啲成績公布出嚟啦，咁就可以多啲俾呢啲病人有選擇。
And then lastly, I wanted to mention 4 other mutations that could be seen with targetable drugs in non-small cell lung cancer, and those are the MET exon 14, the BRAF, the NTRK fusion, and HER2 mutation. These all have relatively new agents that are FDA approved that can be used for patients in the frontline setting.
咁你聽汪醫生講咧，你就知道咧，其實任何嘅基因突變咧喺UCSF 嗰度嗰啲醫生咧，就係佢哋係真係對啲藥咧係非常之熟悉咯。你做咩嘅有咩基因突變咧，佢哋係可以知道用咩嘅藥嚟同你醫嘅。咁所以呢啲咁嘅不同嘅基因突變咧，你可以睇到個藥物嗰度咧就有不同嘅藥物去醫噶啦。
To basically summarize and conclude, even though stage 4 lung cancer is incurable, we do have many different new drugs currently in clinical trial, including vaccines and cellular therapies that I didn't talk about today. And so we at UCSF highly encourage patients to consider participations in clinical trials. And so the benefit of the clinical trials is, one, you can access new drugs potentially for free, and then it can further inform science and help future patients and perhaps also help current patients as well. So I've included 2 resources that can help patients identify what clinical trials might be available. One is clinicaltrials.gov. This website shows all of the clinical trials, not just in the United States, but worldwide. And then you can search by your type of cancer, by geographical location. And the second one is more specific just to trials currently available at UCSF. And then many times, I've encountered patients who are very overwhelmed when they're initially diagnosed. And so if you want to be seen at UCSF, we do have new patient navigators that can help you get plugged into the system and then refer you to the right people, whether it's medical oncology, radiation, or surgeons. For that first consultation. And then I'm putting in a plug for our clinic with a phone number here. And then just please know we're always here and happy to help. Thank you.
Thank you so much. 咁呢個咧就係當一個癌症嘅病有一個病人發現咗突然間有癌症咧，佢係非常之驚慌同埋好彷徨嘅。咁到底要點做咧？咁第一樣嘢咧，我哋就希望俾啲鼓勵你哋啦，就係因為而家咧對癌症，尤其是第4期癌症嘅病人嚟講咧，都唔係話即刻話會死嘅，係咪？因為而家有好多藥咧係會將嗰個生存期咧係拉長嘅。咁咧正話已經講過好多嘅藥啦。咁加上咧仲可以有啲疫苗咧係可以防止癌症啊，仲有啲細胞嘅療法咧，佢今次咧因為時間關係係冇提到嘅，但係即係總之嚟講就係有不同嘅方法咧係可以幫啲病人嘅咯。咁咧就唔需要太過覺得係冇希望啊。咁咧我哋咧就當然係希望鼓勵啲病人咧係會參加呢個臨床嘅研究嘅，因為有啲人咧食某種藥食下又冇效，又換第二隻藥食下又冇效，咁你食到所有啲藥都食完啦都冇效，咁點咧？咁咧嗰啲醫生咧好多時咧都話咁你或者參加呢個臨床研究，而家有啲新藥，因為係新藥所以對你可能有效嘅，咁所以咧就係即係呢個唔係淨係話參加研究，你亦都可以免費得到啲新藥啦。第二咧就可以幫到我哋睇下到底呢個藥有冇用啦。咁希望如果真係有用嘅話咧，咁呢啲藥就係可以幫到以後有肺癌嘅患者嘅，所以係即係可以叫做救人勝造一級浮屠，係咪啊？咁咧就咁點樣知道參加乜嘢嘅研究咧？咁就有寫咗2個方法出嚟俾你嘅，一個咧就係呢個clinicaltrials.gov 呢個網站，呢個網站咧係全世界嘅。所有全世界任何地方做嘅任何嘅研究都會擺咗喺裏邊嘅，你可以選擇你係邊種嘅肺癌，然後咧你嘅地方喺邊度，咁佢咧就會打啲資訊俾你，話俾你聽有啲咩研究喺個地方做緊嘅。咁第二個咧就係我哋自己 UCSF 啦，我哋就做好多嘅癌症嘅藥嘅研究嘅。咁咧就如果你唔知道點樣咧，就請你打個電話嚟啦，就41588538882，打呢個電話嚟咧，就會有一啲調協員咧就會教你睇下你嘅情況係咩嘢啊，咁咧然後咧就教你去你可能要開刀啊，如果你嘅醫生話要開刀嘅，咁就去呢個呢個地方啦，見呢個醫生啦，咁然後咧或者你係食藥嘅，咁食咩藥咧唔知道，咁你就或者揾呢個醫生啦，喺呢個地方啦，咁我哋咧係會盡量幫你嘅。咁好多謝各位今日嚟參加你嘅講座啦，係咪啊？即係希望呢啲嘢你哋係唔需要用到，但係需要用到嘅時候咧，你就請你記得係喺肺癌呢方面咧，雖然係一個非常之嚴重嘅肺癌，但係有辦法可以幫到你。So now we come to the Q&A period. So let's see what questions we have. 你哋仲有冇問題就請你寫落去啦 ，OK?
Thank you for that very informative and fantastic presentation, Dr. Wang.
多謝 Dr. Wang 醫生。
Now on to the question and answer session. So the first question is chemotherapy or medication targeted therapy based on the molecular profile of the cancers that we resect. I believe that was during my presentation. And the answer is yes. So we do give chemotherapy and targeted therapy based on the molecular profile of the tumors if they are intermediate or high risk on the results of the assay.
咁呢條問題咧就係問話做化療或者用藥咧係咪一定要用呢個分子嗰個化驗法啊？咁即係睇到嗰個分子嗰個係乜嘢基因啊咁樣。咁咧個答案係嘅，因為我哋你記得正話有張圖片咧就係話你首先你嚟到嘅睇症嘅時候咧，我哋第一樣嘢就要確定你嗰個真係肺癌啦，即係冇搞錯到啦。咁跟住咧就要做你嗰個分子基因分解噶啦。咁所以咧就用由於嗰個分解嗰度咧就去決定你用咩嘅藥嘅。
The next question is there any data to show that chemo for low-risk patients causes a significant improvement in survival rates at 5 or 10 years? And the answer is yes. I didn't show it during my presentation. But we published this data last year that shows that patients can have up to a 25 to 30% improvement in their survival who are high risk if they're given chemotherapy after surgery.
咁啊，呢個第二條問題咧就係話有冇證據啊話做完手術之後咧就俾即係就算係未做手術啦，如果即係話俾呢個化療啊，係咪會真係可以幫到嗰啲人增加個生存率咧？咁個答案亦都係話係嘅，即係正話你都睇到有張圖片咧，就係話做完化療之後，佢將佢分開高危低危噶嘛。咁如果係高危嗰啲人咧，佢係可以將佢嗰個存活率拉長嘅。
Next question is adjuvant radiotherapy concurrent with the resection advantageous? Great question. So we do that intraoperative radiation if there is a question of margins in the operating room. So if the tumor invades the chest wall or other parts of the chest and we don't feel we can resect it cleanly, then we will give concurrent intraoperative radiation therapy.
咁咧，呢個係一個非常之好問題。佢話會唔會喺呢個開手術嘅時候一齊做埋呢個電療啊？會有用咧？咁啊，柯醫生咧就係話，咁啊睇下個手術嘅情況。如果嗰個手術咧，如果佢你發覺咧係嗰個肺癌嗰啲細胞啊，係喺正嗰個邊嗰度，好近嗰個肺隔離嗰啲膜啊嗰啲咁嘅啦。咁而嗰啲醫生咧覺得可能切唔晒，可能切唔清啊咁。如果佢有咁嘅懷疑咧，佢就可能喺嗰個做手術嘅期間啊，落埋電療一齊，咁就將嗰啲切唔到嗰啲細胞咧，或者附近切咗嗰個位咧，就再電一電佢，咁就希望能夠清咗嗰啲肺癌細胞嘅。
One more further question: Can the molecular assay be assessed at any time or only at the time of surgery? It can be assessed any time, but adjuvant chemotherapy, we've studied it in the setting of giving it 6 to 12 weeks after surgery. So we can get the answer of the tumor anytime, but we have to give the chemotherapy within 6 to 12 weeks of surgery.
咁咧就呢條問題咧就話，咁你去查嗰啲分子啊，咁係咪可以幾時查都得㗎？咁咧柯醫生咧就係話，你係可以幾時查都得，但係咧就係如果係要做呢個化療嘅時候咧，你就要喺手術之內嘅6個至12個禮拜之內要開始，即係唔可以等太耐咯。
Dr. Wang, maybe you can answer this one live. Is there an age limit for chemo? Can a person be too old to undergo chemotherapy?
Yeah, that's a great question. So technically, we don't have an upper limit for age. But we look more at the functional performance status of the patient. There have been a lot of data suggesting that if the patient's functional status is very poor, what I mean by that is, if the patient can't even get out of the house, all they do is basically lie in bed, with a very poor functional status. In those cases, giving them chemo could actually hasten their decline rather than help. And so even though there's no absolute cutoff for age, you could have a young person with very poor functional status that would not be eligible for chemo. Whereas I've actually recently treated somebody who's over 85 with chemotherapy, but that person had a very good functional status.
呢個問題咧就係話，做呢個化療啊咁毒，咁會唔會話過咗某一個年紀咧就唔可以做啊？咁係咪有個年齡嘅限制咧？咁啊，汪醫生咧嘅答案就係話，其實唔係年齡做限制，係嗰個人嘅體質啊做限制。如果嗰個人係就算係85歲以上咧，佢最近有個病人85歲以上咧，佢做咗化療咧，結果都非常之好嘅，冇咩問題嘅。咁咧，但係咧，如果有個人啊，就算後生啊，佢如果係起身啊、行路啊、做嘢都有問題嘅啦，即係個身體嘅功能非常之唔好，即係差嘅啦。你再俾啲化療佢咧，咁啊真係可以害咗佢嘅喎，即係得唔到好處，仲可能會變壞嘅。咁所以咧就要睇個情況咧，就唔係淨係睇年齡，係最緊要咧係睇個病人本身嘅體質係咪好孱啊
？This question is, when would CyberKnife instead of VATS be chosen? That's a great question. So this is stereotactic radiation therapy for nodules instead of surgical resection. And the answer is that the recurrence rate for radiation CyberKnife is still higher than surgery. So CyberKnife is used if a patient is not qualified for surgery. Otherwise, surgery is preferred for patients with lung nodules and early stage lung cancer.
咁呢個問題咧就係問嗰啲radiation therapy 啦，就會唔會係做嗰啲咧比較一種特別嘅 radiation therapy 叫做 CyberKnife 啦嚇，叫咩刀啊？咁咧因為佢整落去咧係好似把刀咁樣將嗰啲癌細胞切死嘅。咁咧，但係個 question 咧就話會唔會係做呢啲咁嘅電療咧係會比做手術咧會好啲？咁柯醫生咧就係話到而家為止咧嗰啲證據咧就係話如果你可以做手術嘅咧，手術嘅結果係最好嘅。你做唔到手術咧，咁你咪諗做其他嘅嘢，就係譬如化療啊咁咯，譬如係呢個電療啊咁咯。
Thank you. And then the last question is for Dr. Wang. I'm a stage 4 lung cancer non-smoker, taking Tagrisso for 3 years. The question is, how long will this medication continue to be effective?
Yeah, so first of all, congratulations, because you've actually exceeded the median progression survival as shown in the original FLORA trial. So the median progression-free survival in the FLORA trial for Tagrisso was actually between 16 to 18 months. And so typically about 1.5 years. Although there are certainly patients that respond much longer than that. And then we've actually had patients where even when they progress, it tends to be only like a couple sites. And then sometimes we would treat those selective sites with radiation, and then keep the patient on Tagrisso and then just treat those sites selectively. So in your particular case, I certainly hope that Tagrisso works for you for basically many 3 years. It's hard to predict. But I think you can take comfort in the fact that even if Tagrisso stops working one day, we have many, both FDA-approved treatment options as well as clinical trials in the pipeline. And so you should have a lot of options for next-line therapy.
So, 呢位黃女士咧就係話佢而家有第4期嘅肺癌，咁食緊呢隻藥叫 Tagrisso 啦，咁咧已經食咗3年啦，咁就係問話咁呢隻藥到底仲可以食幾耐先至會話變冇效啊咁樣，咁咧Dr. Wang 咧就首先咧就恭喜佢嘅，因為 Tagrisso 呢隻藥咧通常咧就係可以將個生命維持大概1年半到嘅啫，但係呢位女士已經係食咗3年㗎啦，即係佢個反應係非常之好嘅。咁至於話幾時先至冇效咧，呢個係真係估唔到咯。咁但係阿汪醫生咧就係話唔使咁擔心，因為就算呢隻藥冇效咗之後咧，都有其他好多嘅藥係可以接班去俾你食嘅。咁另外咧就係話就算食呢隻藥佢冇效咧，就可能啲癌細胞擴散到嘅地方咧，都可能係1-2個位置嘅啫。咁我哋如果係可以攞到嗰2個位置嘅準位咧，係可以用其他嘅方法咧，去將嗰啲癌細胞去控制住嘅。咁即係話咧，係繼續可以將呢個生命延長咯。咁希望黃女士係繼續抬起個頭可以係開心啲去過你嘅日子，就唔好為啲藥擔心得咁緊要。咁我哋亦都係好多謝你分享嘅。
Thank you so much, Diana, and thank you for everyone for participating.
So thank you so much, Dr. Wang and Dr. Kratz. 我而家咧就我哋而家到尾聲啦。咁咧就有幾點咧就想提一提大家嘅。如果你哋係未參加我哋嘅listserv email 咧，我哋好多時都有好多健康嘅信息，或者仲有個資料喺個電郵嗰度發俾你哋嘅。咁就請你去呢個 ahi.ucsf@gmail.com 呢度寫封 email 俾我，話 please add to listserv 咁就得噶啦。咁寫低你想用嗰個 email address 俾我啦嚇，因為你好多人有幾個 email address 噶嘛。咁咧就呢個知其一啦。第二樣嘢咧就係提醒各位咧，我哋係有一個網站嘅。咁呢個網站上面咧亦都有好多信息嘅。咁我哋做呢啲咁嘅 遙距嘅教助咧，好多都喺上面嗰度有嘅，嗰啲 YouTube 嗰啲link 咧喺晒上面嗰度嘅。咁第三樣嘢咧，我哋都喺 Facebook 嘅。咁如果係各位參加講座咁樣，你可以擺上 Facebook 嗰度㗎。你話我今日下晝5點鐘去參加呢個講座啦，你哋有興趣都嚟聽啦。咁係幫到我哋叫多啲人嚟嘅，因為即係通常嚟講就我哋做講座還我哋做講座啦，但係參加嘅人當然係我哋希望越多越好啦。咁咧做完講座之後咧，亦都會將呢啲講座嘅資料咧係錄影咗，然後放上網嘅。所以喺嗰個電郵嗰度咧，亦都會係喺個網上話俾大家聽。So thank you so much for watching for this website and add yourself in as much as you can and invite your friends. And of course, we have to thank Dr. Wang and Dr. Kratz. And we also want to thank our media partner who has done a great job, KTSF Evening News. They interview our speakers, they interview patients, and try to promote the idea that, even if non-smokers, they can have lung cancers, especially Asian females. And our production team includes Longan and John Mohani and Raymond. So 咁我哋係好多謝所有嘅醫生啦，同埋KTSF 呢個坑嘅新聞啦，同埋我哋嘅同事一齊幫我哋做呢個講座嘅。咁當然我哋唔可以忘記你哋啦，多謝你哋嚟參加啦，冇咗你哋我哋點可以做到講座咧？係咪？咁啊多謝各位參與，祝你哋健康，同埋請你哋保重。And 咁今日咧就到此為止啦，多謝各位參加。Thank you.
Thank you. Good night.
Thank you.